I'm Leslie Elliott Boyce, and I'm speaking today with Dr. Andrew Hartz of Open Therapy Institute. And this is episode 3 of a series of conversations that we've been having. And today, wanted to talk a little bit about criticisms of therapy that we're seeing out in the culture right now. And I've been one critic. I've been critiquing the way that therapists are being trained and activism in the therapy space, but I'm just one of many people who are calling out some issues around the way that therapy is impacting the culture. But perhaps we can dive into that a little bit more and talk about what maybe we should be attending to in these criticisms and get into them with a little bit more nuance.
Yeah. Yes, I think over the past year, there've been a lot more criticisms of like therapy and maybe concerns that therapy can have harms if it's done poorly. A lot of this has been in the field for a long time. For example, concerns about rumination. There's a lot of literature that's goes back decades about the harms of negative ruminations. And that's not a secret. I was trained to think about rumination, and a lot of therapy isn't encouraging people to ruminate more. It's actually helping them ruminate less by talking about why they're ruminating, what they're trying to solve, maybe cognitive distortions that are happening when they're ruminating, things they can do that aren't rumination, or ways they can reflect on situations in a way that's more constructive. That's a pretty integral part of therapy. So, people who are concerned about excessive rumination, therapy is often a treatment for excessive rumination, not something that fosters it. Now, therapy could be done in a way where a therapist encourages patients to ruminate a lot, and that would be bad. But I don't even think that's quite the norm. I don't think that's the majority, or even necessarily a large minority of the therapy that's happening out there. Most therapists know about the harms of excessive rumination.
I think that brings up a really good point, that a lot of the criticisms of therapy are criticisms of bad therapy. And there's a blanket association of the therapy profession and this process of working with a therapist with those bad examples, those examples of how it can be unhelpful.
Totally. And the older model, when things were more psychoanalytic and you'd go in week after week and the person was just flat, doesn't say anything, doesn't offer anything. You kind of say, hey, I feel like you're not doing anything. And they'd say, that's what you think about your father or something. And it's just not, just this kind of unhelpful, critical type of thing. There've always been, ways to do therapy poorly and ways to do it in an unconstructive way. And that's true now too.
Well, one of the things when we were talking about discussing this that you brought up was all the sort of pseudotherapy jargon that we hear that's proliferated the cultural conversation. And I wonder if you could expand on that a little bit.
Yeah, like there's an idea that if you're exposed to challenging content in a classroom, that will traumatize you. And that the most effective way to deal with that is to ban the material for everybody at the school. I mean, that's just not accurate. If you have trauma, most of the therapies are about trying to confront it and work through it so that you can live a normal life doing the full range of things people need to do. We can't just not talk about certain issues because some people have trauma. That's not an effective way to deal with that. Another one that you hear sometimes is people will say they have trauma from related to cultural issues about racism or sexism. And because of that, that entitles them to be aggressive to other people, or something like that, or letting people who've been traumatized be aggressive is healthy or
Mm,
something, or it helps them heal.
mhm,
There's just no evidence for those things. If you were traumatized, being aggressive will probably not resolve your trauma. It could
mhm,
make it worse. And it's obviously hurts other people too. But you kind of hear these language, like words like anxiety, trauma, mental health, protecting people from harm, this type of thing. This language is really thrown around a lot, and it's often misused. I think it's often even by people who should know better. Like a good example that would be trigger warnings. Trigger warnings are like if you're going to read a book that has a upsetting scene, maybe a scene that has a sexual assault in it or something like that, the professor is supposed to give a trigger warning saying there's a sexual assault in the book. The research really indicates that the trigger warning heightens negative responses to the event. It makes it worse, because it cues this schema that you're sensitive, you're fragile, this should be traumatizing
mhm,
to you, you shouldn't be able to handle this. So a lot of these things that are supposedly to help mental health actually make it worse. I think that the proliferation of this kind of psychological kind of sounding language, this mental health sounding language that's misused, it does make people lose trust and respect in the mental health profession because they think it's coming from professionals. And it is coming from some people in the field, but I think the general practices in the field are that this stuff is not accurate.
mhm. I think that's a really good point about trigger warnings and the avoidance of touchy materials for people. It's actually anti-therapeutic to employ these kinds of techniques.
Oh, yeah, avoidance increases anxiety. It's not an effective treatment for PTSD is long-term avoidance. It's not the effective treatment for any disorder.
Mm.
Um, yeah.
What do you think about the use of the word trauma? We hear this used quite a bit right now. And as you're kind of talking about these words that are being thrown around a lot, the word trauma has been used so much that it's almost hard to determine what it actually means anymore.
Yeah, totally. And a lot of it was attributed to the book The Body Keeps Score,
Mhm,
which I think was a great book. I really liked that book, and I think the science in the book was really solid. It was really well written, but there was this sense of kind of, I think a lot of people took the claims in that book and overgeneralized everything's trauma, everything's
mhm,
complex trauma, everything's this, everything's that. And uh yeah, and it has this cultural cachet because if you're traumatized, you kind of can get power,
mhm,
and then people kind of can use that to be aggressive. Again, none of that makes sense psychologically about why we'd want to say if you're traumatized, you get power and get to be aggressive. That doesn't make any sense
mhm, mhm.
socially, but that's the norms that have kind of emerged.
Would you talk a little bit more about that book? Because it's been criticized and mocked quite a lot lately. And it's on my reading list. I've actually read the beginning of it a couple of times, but I've never
Yeah.
finished the entire book. So here's a book that I've started and I thought seemed pretty sound and pretty interesting, had come highly recommended. And now there's a lot of criticism of the author in the book, and I'm curious to get your take on that.
I mean, I thought the science that he drew on was really solid,
Hmm.
but I haven't heard all the criticisms of the book, so there might be things I'm missing, but
Hmm.
my, my my sense is that it's misread and overapplied. The patient population that he's working with is really traumatized
Yeah,
people.
they're
You know,
war
people
veterans.
war veterans, people with chronic sexual abuse in the family over years and years. I mean, this is like it's not somebody who was bullied briefly 1 year in school. It's like these are really intense cases that he's talking about for the most part. And it's if you apply the treatments and the formulation of this really severe population to just everyone, then it won't work. It won't make sense. That's my guess about what's going on.
Overgeneralization of the principles.
Yeah, and that happens with all kinds of terms, like everybody thinks, a lot of people think they have OCD and they don't. That, some of it is related to the field, like depression is a diagnosis that has such incredibly weak diagnostic criteria. It's 2 weeks, 2 weeks of more depressed than not. That's an outrageously minimum threshold. And it's not like that for every disorder, but yeah, people glom onto the diagnostic criteria. They misunderstand it. Everybody in their life's a narcissist. Everybody has borderline personality disorder. And you hear enough of this crap and it just makes you hate the mental health field because it's so annoying to have people, analyzing you or labeling themselves and then making demands and saying, I have OCD, you can't do this, you're a narcissist if you just like, it's insufferable. So, I mean, but it's not, I don't think it's an accurate picture of the field and how therapists work.
Seems like a lot of therapeutic principles sort of proliferating popular culture in general, affecting popular culture. And then when that proliferation happens, there's a general, just like with any trend, there's kind of an anti-trend. That's the pushback on that. But in this case, because these principles have sort of escaped the lab, if you will, there's the pushback towards this perspective and this way of looking at human beings, categorizing people, thinking so much about, like you said, disorders and whatnot. It ends up, the blowback comes back onto the profession.
Yeah, and there's probably another thing that's going on is there's a huge range of skill among individual therapists. It's really, really broad. And the really talented people charge a lot of money, and they're often harder to get in general. And then there's been this kind of like oversaturation of things like BetterHelp, really cheap telehelp, teletherapy model that pulls for people right out of school, minimal training. And teletherapy is it might be another piece of it because the connection between the two people is weaker. You kind of open something up and you feel less supported in it because that you don't have the same type of connection. It's harder for the therapist to get a read on how somebody feels. Like when I'm meeting with a patient, a big part of what I'm thinking about is what I'm feeling in my body. And if the patient is, sometimes they look fine, but I feel the anger or I feel depression or I feel anxiety or something like that. And then I can kind of get a sense of like, are you feeling anxious? That signal is so much weaker in teletherapy. And patients might have like another browser window open or something. And then it's like, yeah, there's no wonder you're not finding this as helpful as it might otherwise be. You can't make eye contact. And there was something about the pace of therapy and the way that I think it's structured where the drive or the subway ride to the therapist's office, you're getting into that space and you're reading something. You get buzzed into the room and you sit in the waiting room and you have a minute or two and you flip through the magazine and then the door opens and you go in and you sit down and there's this whole process to getting oriented and then when you're done, you go back. And that's totally different from like you're watching YouTube and 30 seconds before you close it or you hit pause and then you open up this other thing. But so I think there's lots of reasons why people might become less enamored with it. But I would say when people have bad experiences on teletherapy, they very rarely think this would have been way better if it had been in person. They tend to think, this is therapy doesn't work for me, or I don't like therapy, or they don't think that way.
Mm-hmm. As someone who's seen a number of therapists over my life and always believed in this field and this process, I've noticed that it's difficult to find, it can be difficult to find the right match for yourself. You've seen people that maybe you clicked with really well and you felt like there was a great deal of exchange and help and healing that you got through that process. And then other people who weren't really helpful for you because they just didn't get you, or you just didn't get them. And I think the idea of these sort of pop-up or internet BetterHelp type therapy relationships, that seems like it would be really difficult to know that you're getting a good fit. It's sort of random, isn't it? Not as much opportunity to vet the person.
Well, you can shop a lot.
Okay.
And I don't know how many people actually go see a dozen therapists and then pick the one that they think is best. I'm not sure that they would always pick the one that's best. Maybe they pick the person that's the most agreeable, or tells them what they want to hear. You know, that's not necessarily the best person. You know, and another piece is that there's the mechanisms of therapy and what's operating are some of them are hard to articulate really succinctly. So there's this kind of mystification about what the therapist is doing. I think in a society where people are losing trust in every institution, the idea of just trust that there's this kind of secret sauce that works, that's not appealing to people right at this moment. I'll give one example to kind of illustrate it. But when I was trained, the focus of the therapeutic process, really, the focus of my training was all about attunement, an attuned response. And so I'll use this kind of numerical system. If the patient comes in at an anxiety level of 9 out of 10, they're really anxious, okay? The therapist shouldn't be exactly at 9. If you're exactly where they are, that's not very helpful because you're kind of just as worked up as they are. And you definitely don't want to be at 10, because that kind of signals they don't want to open up, because you're actually intense. You're mirroring back to them something that's even more intense than where they are. You also don't want to be at like a 3, because then it seems like you don't care or you don't get it. So you're really trying, if they're at 9, you want to be at like a 7, 6 or a 7. Right? And there's something about that, like, I get it, I'm with you, but I'm a little bit more grounded than you are. That's how people kind of can regulate down. This happens with like mothers and infants, where the baby's really worked up. You kind of go like, oh, what's going on? What's going on? You kind of like, you're there, but you're a little bit less, and you kind of gradually go rocket down to a more comfortable level. Now, people sometimes who get stuck on anxiety, maybe, for example, they haven't had that modeled for them very well. They don't have a lot of experience with that mirroring process going well. So they think when they got upset, their parents always got more worked up than they were. So they learned to shut down, or their parents didn't react at all. So they would kind of freak out, or whatever it might be. So you're kind of training them with a different model that takes time to internalize, and so that then they can do it with themselves. But this is all happening on a nonverbal level. And I think people do get a sense of like, I was really anxious and this made me feel a little bit better. And then it happened again. And then they kind of learn how it works. And then maybe they can do it with themselves. But it takes time for that to sink in. And that's just one mechanism. People are very focused on like, what's the advice? You know, I want tools. I want skills. It's not this kind of internalization of a nonverbal interpersonal process. That's not on most patients' radar of what they're learning to do. And that's not what's needed for every patient. That's not necessarily going to be the focus for every patient. But there's this kind of to explain all the different mechanisms, it takes time, and you can do it with patients, but I think it leads to this mystification about the process, and then they're kind of like, you should be able to tell me exactly what therapy is doing really succinctly and exactly how it works, and it's just not like that.
It's a more complex relationship. I think that's a really beautiful example that you just gave. And it also seems like that kind of attunement is another thing that's much more difficult to perform or enact or participate in when you're on a screen with someone. You mentioned a whole
Yeah.
lot of issues with telehealth, and I use it a lot with clients. In a non-clinical, I work non-clinically, but I use telehealth quite a bit. I also do see people in person, and I think my sense is that telehealth or teleconferencing is better than nothing. It's still an opportunity to connect. We have there's strength in the ability to do this kind of thing. Like you and I having a conversation right now, we can really engage in a good conversation, but there are so many elements that are either dulled down or absent when you're engaging with someone across a screen instead of in person. And that you mentioned a reduced bodily sensitivity. You're not picking up on all the nonverbal cues in the same way. Often you don't even really know what a person fully looks like. You just see head and shoulders.
Yeah.
You don't have a sense of their physical presence. And it's and the waiting too. I think that was a really good point that you brought up. The whole experience of engaging thoroughly in a process that you've decided to do. You've decided to undertake this relationship, this relational process in order to heal or to work on some kind of personal transformation that is important to you, and having to take the time to go to an appointment, wait for it, drive back or ride back with the thoughts in your head about what you just talked about and what just came up for you, that gives that entire process a lot more gravity than just interrupting your cooking to come and switch on the computer for a little bit and then go right back to it. And again, I think it's better than nothing, but it's a different thing. It's really fundamentally changing what you're doing.
100%. Yeah. And, and therapy started, this is thinking about the kind of ritual of going to the office and waiting, therapy started as an offshoot of hypnosis. What basically Freud struggled to hypnotize people.
Mm.
And it was really his mentor, Breuer. This first case was Anna O. And he found that he couldn't hypnotize her. He was trying to treat her with hypnotherapy, and she couldn't hypnotize. So then they just kind of talked about it without this kind of pseudo-hypnotic induction, and she'd just talk. And then that worked. And so it was kind of like, well, it's not hypnosis, but it's not just regular talking either.
Mm.
It's a different type of talking where things are flowing more freely, and you can kind of see more of the irrational, dreamier side of who you are. It has a totally, and not that that's not the way that most people practice these days, but it's not just a regular talking. There's something a little bit different about it that can make it more freer and more open to the unconscious, and that has potentials to create insight. But it's not if it's just treated as a regular phone call. It's that limits it a little bit.
That brings, I think that brings better perspective to the whole blank slate therapist, not really engaging, just observing.
Right.
If you're trying to be pseudo hypnotic, I can see how that actually makes some sense.
Well, and Freud wasn't actually like that.
Really?
He would tell patients about dreams. He gave them gifts. He wrote letters to them, and like he did all this stuff that in his papers on technique, he basically said not to do.
Don't do this.
Don't do this, but which he did. And he would have long sessions and informal sessions, and but I think he was worried about psychoanalysts breaking boundaries, and so he wanted to set a tight frame around it, and that ended up getting entrenched.
Mhm.
even though he didn't really practice that way himself so much.
Mhm. Well, you brought up the wide range of, I guess, clinical skill and and the differences in therapists, that there are some people who are highly skilled and highly capable, other people who may end up being highly skilled but are still new, or maybe aren't as highly skilled. And so there's such a variety of experiences that a person can receive just by doing this process with different people. And I thought about my own training when you were talking about that. When I was in graduate school, I started out in person on at an in-person campus, and I had a couple of really great professors. I had some really good classes that I felt like I wanted to soak up every minute of these classes because these professors were so good. One of them was a group therapy class, and one of them was a counseling, communication, and skills class, both with just excellent teachers. And when I moved to an online program, it was COVID, and I'd also transferred because there were some social justice ideology pressures in that program that I was hoping to escape. I really thought maybe it was because I was in school in Seattle and it was a really kind of woke place, and maybe if I transferred out, it would be better. But one of the things that I experienced when I went online, this kind of goes along with what you were talking about the loss um, of so many qualities in the online engagement with clients, but also with students. I felt like I was kind of in a mill once I went to online school. The the professors were probably great, but it was really hard to tell because I'm just in a Zoom room with a whole bunch of other faces. The engagement was lower. Most of the work that we did was just posting on forums and then reading on your own. I really felt like I could have gotten that education just as well if I'd just been assigned a reading list. And
Mm.
so the opportunity to practice skills was lower too. So I think that there's something missing from the training process right now that maybe doesn't equip people to do the kind of work we hope we're going to experience when we go see a therapist.
Yeah. Well, and they don't want to, I see it in training programs here. They don't want to commute to see their supervisor. They don't see their own therapists in person. They don't see their patients in person. And they're missing a ton of really vital aspects of training. I mean, how much is communicated with a look? Somebody's looking at you and you get a sense of like how they see you. That'll happen. Somebody's maybe they're really evaluating me a lot.
Mhm.
Um, that's interesting. Like, um, maybe they're feeling insecure, maybe they're, um, I don't know, or maybe they're withdrawn and they won't look at me and they sit off in the corner or something, and and I can kind of look in at how they're doing and show that I'm curious about them. It doesn't really happen on Zoom. Um, Yeah, and and I do think a lot can happen on Zoom, a lot can happen on phone sessions. But it's really limited.
Mhm.
Um, can I actually, there's one other thought that I have that I want to make sure to share about
Yeah.
this issue of the value of therapy and skepticism towards the
Mhm.
field. Um, a lot of the value of therapy is that it's like human, it's in-depth, it's idiosyncratic. The generic information about mental health, people know what that is already. It's like, diet and exercise, work-life balance, sunlight and, you know, fresh air, um, not too much drugs and alcohol, get good sleep, uh, don't ruminate, you know, it's pretty, people know the basic stuff. Um, the details of what gets them stuck. I mean, if I actually have a few sessions, few 45-minute sessions to really learn somebody's story, I can get a sense of what their blind spots might be. Where are they stuck? What's unique about their situation? So that's something also that's like hard to mass produce. So if I'm saying what's good for people with ADHD, it's like make a list, keep a calendar. Like it's like those are good things. But then it's like, oh, this person with ADHD, their symptoms are really exacerbated by anxiety or self-criticism, or they try to do more than they can, or whatever it might be. There's this idiosyncratic pieces that you you can't just read a book about. You have to, like, it helps to be with somebody about. So that's another example of when they come in for the first session, they're gonna be like, what are you gonna do to me? What are you gonna do for me? How are you gonna help?
Mhm.
And you're kind of like, I don't know.
Mhm.
I like let's see what comes up. But if you're stuck on something, as we unpack it, we should see opportunities to think about things differently or do things differently. And some of those might be generic stuff, it's diet and exercise, but probably the stuff that's more valuable is the idiosyncratic bits.
Mhm. And I would imagine that the ability to engage in that with depth and skill is something that doesn't come quickly, that it's something you have to learn over
Right.
time.
Yeah. And you don't, yeah, and you can start with the simple stuff.
Mhm.
I'll often start like, okay, I'm a I'm a chronic procrastinator. I'm falling behind on work.
Mhm.
Let's start with a list and a schedule, try it out. But if that's not getting you there, it's anxiety, it's perfectionism. Where'd that come from? What are the beliefs and thoughts related to that? Um, how do we reframe things? Maybe they come from childhood experiences even. It can get complex. And that's why it's hard to say, give me 8 sessions. I'm going to do A, B, and C, and then you'll be tip top. So I think but that's from the patient's perspective. I get why that's hard
Mhm.
because it's kind of like open this up. It's a long-term thing potentially. We don't know where it's going to go. That's a hard sell for people, which I totally understand. But the value of it really is in that idiosyncratic
Mhm.
stuff. And you often don't have that much after one session about where it's going to go.
Mhm. I think we're so used to quick results that it's hard sometimes to imagine having to invest like that in a relationship, in a process.
Yes.
Mhm.
And it's like, well, why, like that we're kind of like
Mhm.
hiding the secret, or that there's nothing behind the curtain. It's just like we're just BSing everybody.
Yeah.
To see it, you have to go through it. And you're wondering, is this therapist good? Are they really going to be able to help me? Um, so
Mhm.
it's tough. And in a low trust kind of environment, I think it's really ripe for not wanting to get scammed. And I think that's a reasonable concern.
Mhm. And I think that the sort of the flip side of that concern is as I think you said, was the risk of endless go nowhere therapy, that you can end up having a problem of knowing when it's time to terminate.
Yes. I I do think it's helpful for patients to have a goal in mind. Why are you coming in?
Mhm.
Um, Sometimes something's wrong, and maybe the goal is figuring out what that is. Something feels off, and maybe it's pretty diffuse. I,
Mhm.
I I don't see that very often, to be honest, but that's still something to orient what's going your therapy. But if you have a precise thing, like I want to move out of the house and get a job, I want to like have more energy or not be depressed all the time or not have panic attacks anymore. There's something that can be really orienting. Now, it may happen that as you make progress towards that, you discover other issues, like maybe a relationship issue uh, that you've been ignoring is driving your anxiety.
Mhm.
So maybe you want to understand more about what's happening in relationships with you. So it can evolve, but it is good to have a goal. And as an indication of when you're done. And I would say related to that, don't it's a conversation therapists should check in on if they feel like you're not making or the direction of the treatment isn't clear. I think therapists should check in with that, but patients should raise it too. A lot of times they'll just be really passive about waiting for the therapist to tell them that they're done, but the therapist doesn't know that they feel where they want to feel. So you have to talk about it.
Mhm. One more issue that I would love to talk with you about and hear your thoughts on, but perhaps it could be, maybe we could sidebar it for a whole conversation if you're interested, is some issues around overdiagnosis and over-identification with diagnosis. And I think we see that a lot, especially in young people who are kind of using mental health diagnoses as a core part of their identity. And so this is another area where I think that there's some popular cultural criticism of therapy and therapeutic concepts. I don't know if you want to dive into that, or if maybe we should hold off.
No, yeah, I think that could be a whole conversation. I mean, the DSM is the kind of manual of diagnoses, and it's debated in the field. You know, they're kind of descriptors that are for providers to kind of think about what's happening clinically with the patient and think about what treatment's most appropriate. And they're also used in billing. But they're not some kind of like divine window into the soul. And the criteria change. Every edition they change. Especially the personality disorder diagnoses, like they can be really loose. You know, narcissistic personality disorder can take a really wide range of forms, and two people that look radically different could both technically meet criteria, and somebody else who seems really narcissistic doesn't actually fit criteria. And it's like, this is just like really hotly debated. But I think like there does seem to be a sense that people have that once they get the label, they're like, that's the answer. But it's really just a description of what you're reporting. That's my sense of it. Well, what's your sense of it?
As far as diagnosis and issues around diagnosis,
Yeah.
in my training, something that I found alarming was the emphasis on diagnosis as a must for billing purposes. So this was we would be assigned other students in the program to do mock sessions with, or in our clinical skill building process. And we would be asked to give diagnoses to these other students. And what we were told was, if you can't come up with a diagnosis, tell your professor and they will assign one. They'll find one. They'll watch the video. They'll look at your notes and they will assign a diagnosis. So what this seemed to indicate is that every single person that you could possibly talk to, even these presumably high functioning graduate students, has at least one diagnosis in the DSM. And so I found that kind of troubling. I can also understand why, if you are going to justify this to an insurance company that you're going to bill for this, that you have to have some way to code the process that you're billing for. But I feel like there's that kind of corrupts the work that you're doing if you're also having to hold in mind this billing framework. Like there's an insurance incentive to find diagnoses that can justify the number of visits that your client wants to have, or that you feel like you need to have. And so that we talked about upcoding and downcoding, and these were based on not necessarily what you were seeing with the client, but sometimes you want to downcode because you don't want this to stigmatize the client going forward, and it's going to stay in their record. And there were so many other sort of social and financial reasons to apply diagnoses, and I felt like it's a really fraught framework that doesn't seem very straightforward and has the potential to, if a person knows the diagnosis that they've been given, really impact the way that they're seeing themselves. And it's almost like an astrological sign. It's like you're you're a Cancer, and so you do things like this because you're well,
Yeah.
you have OCD, so you do things like this because you have, and or you know, you have a bipolar too, and so this is, and I think that hearing that about yourself can really change your self-concept sometimes. Sometimes it can be a huge relief to a person to get a diagnosis. They can say, oh, okay, I can understand why I've been so troubled by XYZ in my life. This makes sense. Here's a framework and here's a pathway for me to overcome the challenges that I've been having. But I think sometimes it can be really limiting, and it can shape the way that we perceive ourselves going forward in a really significant way.
Yeah. It's like serving these multiple kind of competing functions at the same time. Of
Mhm.
like, there's this kind of insurance billing thing, and then there's the way that it's internalized by the patient, the way that it impacts treatment. Um, and they're also kind of haphazard. They're not really like, they're not systematic. One thing that to me seems outrageous about the whole thing is there's no real good diagnosis for anger.
Mm,
It just makes no sense to me why you have like anxiety disorders, depression disorders, no anger disorder. The
mm,
things that are close, like you could have antisocial personality disorder. That's not really, that's like a totally different thing where you don't have remorse and commit crimes and stuff.
yeah,
It's not
that's
really. And then there's intermittent explosive disorder where you kind of go berserk and break things or attack people. Um, but what about just like chronic anger?
mhm,
It's not really, there's no like generalizable anger disorder, people that just feel angry all the time and maybe they're like snippy,
mm,
or maybe they're just irritable all the time. And
mhm,
maybe they do get in fights some, but it's not necessarily like an explosive thing where you're breaking furniture.
mhm,
Um, there's just not a good, and I don't know why that's not in there.
mhm,
Um, and then the threshold for certain diagnoses is really low, like depression,
mhm, mhm,
2 weeks of symptoms for depression. And then others, it's like it's very high. Yeah, so I think it's kind of like it's kind of a mess. I don't have a solution though.
mhm,
And I think it's very, very hard to create complex systems like this.
mhm,
It's so hard.
mhm,
Um, and the idea that we could just rethink all the diagnoses or recreate it, I have no suggestions.
mhm,
So it's kind of like, I don't know if there's a way that we could tighten up the diagnoses or encourage patients to identify with them less, or
mhm.
I don't know.
Yeah, it seems like there are a lot of, as something it's become so destigmatized to see a therapist, which I personally think is great because I do think that people can reap a lot of benefit through these kinds of relationships. And but as it becomes destigmatized and popularized, what I guess this whole conversation has really highlighted how concepts proliferate and morph and take on a significance culturally that maybe is different from the intended therapeutic significance of those processes and concepts. And we're kind of witnessing a a cultural, I guess, grappling with how to integrate some of the processes and thoughts and ideas from mental health. And there's been a rejection of some of
Right.
them and an embracing of others and a distortion of some of them. And it all leads to confusion and misconceptions about therapy in some people's minds.
I don't think when they like I don't know. I don't think that there were big conversations when they were making the DSM-5 or the
Mm,
DSM-4s, or what that there was this big thing about like, we got to be worried that like young people are really going to want to identify strongly with these.
yeah.
I just don't think that was like a major concern. Um, and like, what do we do about that? I mean, it's not a window into like, there are lots of different ways to be depressed. It's a description of a
Mhm,
type of experience people have. Um, that's it. But it's interesting that it's like takes on such, because when I was growing up, you were like a skater or a punk or a something, and I guess now it's your diagnosis or something. It's like serves
Yeah.
a similar function about this is
Yeah.
who I am. When you have like a weak identity and you need something to define who you are that's external, this is something that, and people misdiagnose all the time online and mistreat and read into this stuff. They go online and they read about dissociative identity disorder and they're like, I have it. And they're like, they're 14 and, and their friends are saying, yes, you definitely have it. And
the first time I saw it was my oldest daughter, who was born in 96, was middle school aged, and a mom of one of her friends, I was over picking my daughter up from a play date. The mom was talking about her daughter's mental health diagnoses in front of her daughter. And she was talking about her mental and physical diagnoses. And you could see the girl kind of just really paying attention to her mother. And I thought, this doesn't seem like a healthy thing for you to be talking about in front of your kid. It felt strange, because I know how badly kids want to find something about themselves that's special. They want to be able to understand how they plug into society and into their friend groups. They are looking for what makes me me. And if a big part of what makes you you is that you are asthmatic or autistic or whatever these labels are, then I do see that same grouping like you're talking about. Like we used to have Gen X with the skaters, the preps, the punks, the the jocks or whatever it was.
right.
And I do see that starting to happen with young people around mental health. It's really interesting.
Yeah. And then that makes people not like the field because they see it hurting people. But yeah.
Exactly. Wow, this is such a fascinating conversation. I feel like it could go on for a long time, but perhaps this is a good point to stop. And unless there's anything you feel like we should recap or say that we missed in this conversation.
I'm sure there is, but it sounds like a good stopping point to me.
All right. Well, thank you so much, Andrew. It's really been a pleasure to speak with you.
Thanks.